Hello, everyone. I'm Barbara Ham-Lee. If you have high blood pressure, listen up. Striving to get and keep your systolic number lower than 140 may not be enough anymore to reduce your risk of heart disease, stroke, or heart failure. There's a new study that says your number now needs to go below 120. So why the change? What does this mean in terms of medication? Do you need to be concerned? Cardiologist Dr. Keith Newby is here to sort things out and answer your questions at 440-2665 or 1-800-940-2240. It's Another View on Health right after this news from NPR.
Discussing today's topics from an African American perspective, this is Another View.
Good afternoon, everyone, and welcome to Another View. I'm Barbara Ham-Lee. I hope you're staying dry in this kind of damp and dreary weather today, but that's okay. We're going to have a great time here on Another View. So the National Institutes of Health recently funded the Systolic Blood Pressure Intervention Trial, and it's known as SPRINT. 9,300 people older than 50 who had high blood pressure and at least one other risk factor for heart disease were studied, and the results showed such potential for substantial benefit to patients that the trial was ended early so the findings could be published. Our resident cardiologist, Dr. Keith Newby, is with us to explain what this all means. And we also have with us Ms. Audrey Thomas-Tarboro, who knows firsthand what it's like to struggle with getting and keeping her blood pressure under control. Both of you, welcome to the show. Dr. Newby, so good to see you.
Always.
And Ms. Tarboro, good to see you. Audrey, may I call you Audrey?
Yes.
Fantastic. So Dr. Newby, this study, says now, 140 is not good enough if you're over 50. Now it needs to be under 120. Is this a surprise to you? And tell us a little bit about what the study means.
Okay. Well, to be honest with you, it wasn't even remotely a surprise to me. If you look at the way the hypertension is defined, the definition of hypertension says that if you're, and because it's a chronic illness, if your systolic pressure, and that's the top number, is 140 or greater, or if your bottom number is 90 or greater, at three separate occasions, that's defined as hypertension, which is different from high blood pressure. A lot of people use the terms interchangeably, but it's not really the same. High blood pressure could be a transient thing. Say, as an example, you're home one Saturday and the phone rings, or I should say a Friday and the phone rings at 9 o'clock and somebody says, "Hi, this is Joe Blow from the IRS, and we're reviewing your records, and we found that you owe us $100,000 in back taxes. If you don't pay it by Monday a.m., you will be in jail the next day. I guarantee you, if I check your blood pressure 5 minutes later, you got high blood pressure." Now, but after that calms down and somebody calls back and says April Fools, and after you kill them, then if you check your pressure later on that day, I guarantee you it'll probably be lower. Now, that's a transient problem. Hypertension is chronic. So when you look at that data, it says that if you met that criteria, you had a 4-time stroke risk. Now, what we also know is that if you fall in the prehypertension mode, which prehypertension is defined as if your top number is between 120 and 139, or if your bottom number is between 80 and 89. So either or, three separate occasions, that's defined as prehypertension. We know your stroke risk is 2 times the normal population at that number. And we've known that anyway. And I practice always, I've been doing this for years, to push my blood pressures 120 or less. So really, for me personally, that data is not necessarily new, but I don't think the difference is they haven't defined the how it impacts, meaning, you talk about percentages of lives saved, or, a percentage of reduction in risk. That's the part we didn't really know. But we did know that your risk for having an event was high. But on the opposite end, to say how much do we actually reduce your risk by bringing it down, I think that's the data that this trial has really brought to light. So
most doctors and most cardiologists then would really try to get you down to that 120 level anyway? Or
it kind of depends. It's like, I've had some docs I've dealt with who really didn't push the envelope because, that council a couple of years ago said that they didn't care if your pressures were 160 if you were 65 or older. And I just blew that off immediately.
Why is age a factor?
Just because of stiffness of the arteries. As you get older, you develop atherosclerotic plaque, and that's just like joints wear down, arteries get harder. And what happens when your arteries get harder is when part of what creates blood pressure is the elasticity of the arteries, meaning when you have a bolus of blood pumping out the heart, it opens into this aorta, which is the main artery, and the aorta expands and then contracts, and it pushes blood downstream. So the give of that artery kind of defines how high the pressure is going to go.
In order to push it through.
Right. So now if you have a person whose arteries are getting stiffer, it takes higher pressure to push it through, pressures go up, and then you subsequently have a different number. And typically that's why you'll see older person usually their top number is going to be higher than the bottom number. Younger people, oftentimes you'll see where both are up. But as you get a little older, and that's called isolated systolic hypertension, and you'll see that as we get a little older. Now, it varies for different people. I mean, I have, some of that's, lifestyle. You've been taking care of yourself all your life. You'll find a lot of these patients will have normal blood pressures and 80 plus years old. So that's not uncommon. A lot of it is really based on your lifestyle, how well you took care of yourself. If you identify your risk factors and you kind of work on those, typically your numbers will be better. And there's data that says that, a lot of people don't have to always take blood pressure medications. The problem that we've run into is, you can't get anybody to do what they're supposed to do. And you tell them, say, okay, you need to change this, you need to change that, you need to cut down the stress, increase your activity level, you need to cut out the certain amount of sodium in your diet. I mean, you would think you were torturing them, and you run to that problem.
Because we are that society of give me a pill and let me move on.
And let me move on. And half the time, they don't even want to take the pill you give them. So it's like, I just wanted to magically go away, which unfortunately, so is not going to do that. And unfortunately, even more so, especially in the African-American population, what we run into is that patients, because like hypertension, diabetes are characteristically asymptomatic disease processes, and you think about it, if you have an infection and you feel lousy, somebody says you take that antibiotic, you're going to take it because you want to feel better. If somebody says, okay, your pressure's high, take this medicine, but doc, I feel fine, but I need you to take it, but I feel fine. I ain't asked you that. I ain't say that. I say I need you to take it for X, Y, and Z reasons. It's hard conceptually for somebody who feels okay to take something. It's kind of almost like, I think a lot of people feel like, they're sick if they have to take medicine, and they say, well, I don't want to be sick, therefore I don't want to take this medicine. And that's just a theory I have. I'm not sure always why people don't want to take medicine. I mean, I always joke with patients. They know how I am with them. They'll, I just hate taking medicine. And I ask them why. You don't have a problem eating. You put some in your mouth and you're swallowing it. So what's the difference? It's all conceptual. It's a perception, conceptualization of saying I have to do this, and I'm becoming convinced. I think people just don't want to feel sick, and medicine makes them feel like something's wrong, and therefore they don't want to do it. And again, that's just a guess, but that's what I'm coming to this conclusion
that's
over the years. Yeah.
440-2665 or 1-800-940-2240 are the numbers to call. We're talking about high blood pressure, hypertension, and how to keep it or get it under control. Audrey, let's talk about your situation. So I understand you're a retired nurse. Is that correct?
Yes.
Okay. So you're Dr. Newby's patient, one of his patients. Tell us about how you discovered that you had hypertension and what has been your situation in trying to get it under control.
Well, actually, I went to the dentist to get my teeth deep cleaned, and my parents died young with high blood pressure, and my grandparents. So my dentist knew this. So before he would, he deep clean my teeth, he checked my blood pressure, and it was sky high. I don't remember the numbers because that was years ago. But he sent me back to my PCP, and she confirmed that I did have it. But I have to admit, I was in denial for a long time, even working in the health, as a healthcare.
Why were you in denial?
I don't know. I just didn't believe I had it. I just didn't
My
believe.
theory coming back out again.
I just didn't believe it was going to affect me. I don't know why. I don't know why. I just didn't believe it. And I had a mini stroke. I think it was 2003, and I was at work. It was really bad, and I had them call for my daughter to take me home. I didn't want to go to the emergency room, and I knew that something was really wrong by the time.
Healthcare professionals,
I
the
know.
worst patients.
We are. I admit that. And so
Don't say we.
some of
We
us,
awful plural lately.
a lot of us. But they took me to Lee, and that's where I spent about a week and a half, and I had therapy and all of that. And then I came to the realization, okay, you have high blood pressure.
Okay, and at that point, do you know what your numbers were at that point, and what was your treatment? What did you have to do to start to work on getting your numbers down?
Well, I think my numbers were 180 over 120. They were ranging in that
Wow.
number. So they did put me on medication, which I took for years. I did take my medication, Dr. Newby.
That's saying a word. I'm going to sit over here nice and quiet. Go ahead.
And so, as time went on, I'm taking the medicine, and I kept my regular doctor visits. And it was still up, but I wasn't watching my diet the way I should have, because I'm a potato chip eater, or I was. And so, I was still eating sodium more than I should have and being hard-headed. And I lost a kidney in 2005.
Wow.
So after I lost my kidney, that really made me take a look at, what I was doing to myself. And so I have been taking my medication, and I'm trying to watch my diet. I'm not perfect with it, but I do watch my diet.
440-2665 or 1-800-940-2240. What questions do you have about keeping your blood pressure under control? Do you have an issue? Are you on medication? And how do you know when it's time to change that medication if that's necessary? Give us a call, 440-2665 or 1-800-940-2240. I have a question because I'm on high blood pressure medication also. I will admit to that. But I take my medicine. Because I don't want to go through that what you have had to go through. But Dr. Newby, I hear so many different people talk about so many different types of medications that they're on, and I hear people say things about beta blockers and different types of things. Can you talk to us a little bit about one, how a doctor decides what you need, and what are the different things? What does it do in order to bring the pressure down?
Well, I think you have to, for me personally, I look at how high the pressure is when I see them. And, as much as you hate to admit it, there is some racial division with, certain groups I found respond better to certain types of medications. And that has held true over the years. And even as a resident at Emory, that's one thing I noted at Grady Hospital, which is the big county hospital in Atlanta, Georgia. And of course, it was probably 90% African American. Then you go out to the suburbs of some of the other hospitals, Crawford Long and Emory, that you would find it was the opposite. And what I found was there was differences in terms of the response factor. Calcium channel blockers, which is what they do is relax the artery wall, and that lowers pressure by dilating them. I found that group of patients, African Americans, responded better to that group of drugs. Beta blockers, what they do is they're really essentially by the beta receptors, if they're blocked, there are certain beta receptors that will cause a reduction in it's kind of a slight reduction in function, not enough that you notice it on like an echocardiogram or whatever, but it does decrease function to a certain degree, which lowers pressures that way, and it causes some artery dilatation that way. ACE inhibitors, which affect the, there's a enzyme ACE enzyme, which is angiotensin converting enzyme, that gets blocked, and you're preventing an angiotensin 2 conversion, which would usually, if that gets stimulated, that causes arteries to constrict. So if you block it, it causes it to go the opposite way. And the ACE receptor blocker group, what that does is it doesn't block the actual conversion of angiotensin 2. It just blocks the receptor the angiotensin 2 attaches to lower blood pressure that way. Then you have other medications. Those are probably the more common ones, along with diuretics, of course. Diuretics have been the mainstay, but I tend to not. I go with diuretics a lot, but I don't use it as a front line, and that's just my individual thing. Because what I think about is cost. I think about compliance issues. Are you going to take it? And then I think about what else does that drug do. The problem with diuretics is it also enhances or increases cholesterol levels, and it causes hypokalemia, or potassium levels to drop, which means then you have to take yet another pill to deal with the loss of potassium. Now, a lot of us need it because we don't always are not as compliant with diet. We eat potato chips and stuff like that. And
don't feel bad, Audrey. I'm a potato chip eater too.
So that sodium content raises blood pressure. So the diuretics actually kind of release that sodium. But if we really could maintain and lower that sodium level, then the need for diuretics oftentimes will go down.
440-2665 or 1-800-940-2240. O'Neill joins us from Yorktown. Hi, O'Neill. You're on the air. O'Neill?
Hi, can you hear me?
Yes, you're on the air.
Yeah, I'm listening to your program, and I'm just wondering, what's the ideal blood pressure for males mid-40s? Because my blood pressure in May was like 140 over 90, and I started exercising every day, and it's now like 180 over like 80. And I want to know if that's it.
You say 180? 180?
It was 140 over like 90.
Okay.
And now it's like 120. I'm sorry, 120 over 80.
Okay. All right. I'm with you now.
You almost gave the doctor a heart attack.
I'm with you now. Well, actually, and that's one of the things that we talk about is, is exercise, diet does help reduce blood pressure. That was a comment made earlier, saying that a lot of times if people change their lifestyle, that a lot of times that will go down, and that exercise helps reduce that sodium as well. So if your diet, you're watching that diet and your exercise, a lot of times those pressures will come down. So if you're at 120 over 80, personally, I think that's fine where you are right now. Of course, if you look at that cutoff, they're saying less than 120, but I would not put somebody on medicines for 120. Personally. And the reason being is, and you wouldn't be wrong for doing it. But to me, if you drop your blood pressure 20 points just by exercising and taking better care of yourself, you can probably step it up a little bit more and probably get it, down to 118 or less just by enhancing that, weight loss. They say for every 10 pounds of weight loss, you'll drop your pressure 2 or 3 points. So, if you're kind of trying to add some more to that factor, it will impact. And I have seen that before. Blood pressures drop with weight loss.
Okay. Thank you, O'Neill, for the call. We appreciate that. If you are on a weight loss program, and as you start to lose weight, is there an amount of time before you could perhaps come off the medication? In other words, say you're continuing to lose weight and your numbers start to come down. At what point does the doctor say, okay, you're okay now? Do you know what I mean?
Yeah, well, everybody's a little different. Again, the one thing with medicine, why they call it the art of medicine, is mostly because of style differences. What I usually tell patients is if they are on a weight loss factor, I say, I always encourage patients to get those automatic blood pressure cuffs to have at home.
Really, they work?
Yeah. I'll tell you why. Because the unfortunate reality is we as docs have to try to decide if somebody comes to the office and their pressures are high. One of the things I have to decide is that a legitimately high blood pressure, or are they just high because they're here seeing me that day? And that is, and there's a true entity called white coat syndrome. And I've had patients who literally when they come to the office, and this is
because they're so nervous.
Yeah, this is a sound absolutely insane what I'm about to say, but I have somebody in my mind at the office. They were 200, like 210 over 110. I've had people like that. I've actually stuck them in the hospital. Same day they go in the hospital, and they're in the hospital, and you see the pressure all of a sudden just start to come down with no intervention. And then next thing I know, they're 118 over 70, and I hadn't done anything yet. So then I asked them, I said, so you're telling me that you're more nervous in the office than you are in the hospital? I said, okay. I mean, everybody's a little different, but, we do see that. So, so you have to decide that first. So then after that, then it's the issue of they're checking the pressures at home. When I see them numbers drop to that 120 over 80 or less, then I'll start saying, okay, let's start looking at curtailing the medicine. I may say either we'll drop a dose or we'll drop a pill. Like if they're on, because I have some people on 3, 4, sometimes 5 blood pressure pills. And not a lot that they're on that many, but the average is usually 2 to 3, so you'll drop one, see other, and I say keep checking your blood pressures, keep doing the weight loss. You find out where they're trying to get to. And then I usually try to, do it based on that. So I have them keep, checking pressures, send me the messages. I usually have them email me whatever, what the numbers are running. Mm-hmm. And I'll say, okay, then we may have to go back up if the pressures go back up, or if it continues to decline, then we go to the next medicine and then the next one if possible. So I have had people that I've taken them off altogether. So that's my style.
Mm-hmm. Mm-hmm. Audrey, have you been able to come down off of medications, or are you kind of maintaining at this point?
I think, I was in the hospital, was it a week ago, 2 weeks ago, and Dr. Newby got it down then, and it's been down. It's been good since I left the hospital, and he did take away a couple of my medicines, so I'm on 3 different meds now for it. So I'm maintaining.
Do you take your blood pressure every day?
The audience, you already know the answer to that. That silence was all you needed to hear.
Do you recommend that she takes her blood pressure every day?
Well, everybody's a little different. Normally, and the reason why I say that, because some people actually work themselves up by checking it every 5 seconds. My high anxiety, she's a pretty chilled patient. When I say that, I mean, she doesn't get like worked up and excited, like some patients do. So I could ask her to do that, and she wouldn't, get worked up behind checking it. Some people, I don't want them checking at all, because I'm like, they just work themselves up. Then they check it 800 times a day. And I'm saying all you're doing is escalating it up, because you get more nervous. You keep checking it. Stop checking. I'm gonna take the batteries out your machine and ban you from the battery store. It's variable, but usually what I tell them is once we get the pressures down, I usually have them check it pretty frequently. I like morning and evening checks. Mm-hmm. Once I know their pressures are well controlled, then I back them off on checking it. And then we just look at weight and lifestyle change. So then we know when we can actually curtail medicine.
Got you. 440-2665 or 1-800-940-2240. What are your questions about controlling your blood pressure? Ty joins us from Norfolk. Hi, Ty. You're on the air.
Hey, good afternoon.
Hi.
My question was, are there herbal supplements that we can possibly take to help control, like cholesterol and blood pressure and the like?
Well, I'm sure there probably are. I don't really follow per se the herbal, kind of stores and what have you. I tell you what, and I tell people all the time, I don't always advocate medications. I advocate the lifestyle change, because you'll find the majority of the time if you change that, your pressure's going to come down on their own. But if you're somebody who has a high cholesterol, there's data that talks about, if you take in certain types of carbohydrates, lower carbohydrate diets and more whole grains, less refined sugars, you'll find your cholesterol level will go down. I've seen data where, there was a head-to-head trial a few years ago, talking about low carb diets versus low calorie diets, and I felt vindicated seeing this, because I've always encouraged a low carbohydrate diet, but I had a lot of dietitians I get in these debates with, because they always act like you're going to die if you're on a low carb diet, and it said that both diets were very safe, but the difference was the cholesterol profiles in the low carbohydrate group was actually markedly lower than it was. So a lot of people are saying, well, you talking about eating all this red meat or eating all this shrimp, my cholesterol goes up, but actually it doesn't. If you look at it, the problem is when we eat the meat, we eat potatoes. Yeah. We eat gravy. We have
you have to look at all
bread,
the other things that go
other
along
stuff.
with it.
Yeah, and it's really not so much any one individual thing other than the refined, the stuff like the breads, the flour, white, processed flours, anything along that line, you'll find it's not going to be that good for you. Tastes good, but it's just not good for you.
If you're just joining us, we're talking about a new study that says the lower your blood pressure, the better. Cardiologist Dr. Keith Newby is with us to put it all in context, along with Audrey Thomas-Tarboro, who is controlling her high blood pressure with medication. And we're happy you're doing that, Audrey. We want you to be around for a while. 440-2665 or 1-800-940-2240. Robin joins us from Portsmouth. Hi, Robin. You're on the air. Hi.
How are y'all doing?
You're doing fine. What's your question?
My question is, my doctor put me on blood pressure diuretics a couple of years ago when I was at work and I was under a lot of stress. Since then, I've been disabled, so I've been at home, but then they kept me on it to keep the fluid from building up on my left ear. So I don't take it, like, per se, on a daily basis because I don't need it. But I heard say something about cholesterol and potassium. So I want to know if the diuretics could be keeping my triglycerides and my cholesterol up.
Well, it could be, but the thing is, again, the one thing in medicine is you have to take everything in context, meaning, lifestyle, like what types of food you're eating, all that plays a factor. What diuretics can contribute to an elevated cholesterol, but it may not be the only thing that's making the cholesterol level go up. So that's the key thing is what you have to do is look at it in entire context, and that's what your doctor could help you with.
Okay, thanks for that call. Sharon joins us from Hampton. Hi, Sharon. You're on the air.
Hi, good afternoon.
Hi.
I was curious. I'm one of those really crazy patients of my doctors. It's really funny because I heard Dr. Newby have a fit, but my blood pressure, my high blood pressure history is I'm usually in the 220s to over 100, and they call me the walking dead at my doctor's office.
Wow.
Because I have had history of my blood pressure being that high, and I was just curious. My blood pressure came about from it was gestational. It was after I gave birth the second time. I had it with my first pregnancy, and it went away after I gave birth. But the second time, it came, and it stayed, and I have suffered from it ever since. And I have always had high blood pressure with it, and then it gets sky high. I've never stroked or anything like that, and I am on medicines. I have 4 medicines that I take, and I'm just curious if people that are at the higher end of hypertension, are they more susceptible to getting kidney disease? I've had proteins show up in my urine, but once it's been tested, I haven't developed kidney disease. But that's a scary thing for me, and I'm just curious, would I be more likely to develop that than somebody that doesn't have it as high as I do?
Yeah.
I try to take my medicine, but my diet, I'm still kind of struggling with that.
Yeah. Oh, understood. I mean, like I say, I joke with people about it, but, if it was, dietary changes, they're hard to do, especially, our exposures to this stuff every day. We go to any weddings, funerals, any event, somebody's going to try to feed you. And typically they're not going to feed you something that you need. And that's the unfortunate reality. But I almost about ready to tell you, you need to come see me because, pressure that high,
wow.
That's kind of up there. And that's not, but to answer the question, yes, the higher the blood pressure, the more apt you are to develop the complications. Just because you haven't had a stroke, the thing I get fearful of when I have patients whose pressures are that high is not so much stroke from a standpoint of blocked artery, but just intracranial hemorrhage, which means you bleed in the brain from the pressures being so high. And that's something that really, needs to come down because and that's so. I mean, I would always encourage that. And now there are other entities that can also push that pressure up that have nothing to do with you individually. Some people have kidney like renal artery stenosis, which is the kidney arteries are clogged up a little bit. And you see that more in women, actually, not so much from atherosclerotic plaque, but from something called intimomedial hyperplasia, which means that the inside layer of the kidney artery just get thicker. And that could come from various different things, but that causes a chain reaction that raises blood pressure. So there are other secondary causes of hypertension that also could be contributing to you in addition to just diet and lifestyle things. So I really would encourage you to have that relooked at by maybe have somebody else get another opinion, just somebody else to take a look at things and just see could they add some value to your case.
Okay. Audrey, have you made a lifestyle change in terms of your family? So in terms of diet and exercise and all those things, since you have high blood pressure, you said your parents had it. Is it hereditary? I mean, does it run completely through your family? And have you guys made changes because of that?
Well, not in my immediate family. I have siblings with high blood pressure and diabetes. In my home, no, I can't say that I really have because I have teenagers, and you can tell them to eat right, but the story with that. My husband, he's a heart transplant patient. He really does not eat the way he should either. So I hate to say it, but I have to
We're
go
going to have to get a nutritionist over to your house.
You get a brute squad over there.
So, he's back and forth with me and I'm back and forth with him, but I'm going to get it done.
So is high blood pressure hereditary?
Yeah, it's hereditary. Yeah, but
hereditary.
It's a combination of things. So what you'll find, and my brother's a primary care doc in the area. I went to one of his lectures. He lost a lecture on diabetes. And his wife, and they were actually at my church a couple weekends ago and talking about diabetes. But it all kind of comes hand in hand: hypertension, diabetes. And one of the things that somebody asked him was, is diabetes hereditary? And it is true that it is, but he also mentioned, and I agree with him 100% to a large degree, the reason why it seems hereditary is because the lifestyle goes in the family.
With the family.
So if you have a family who are typically not good eaters and they may be overweight or obese, the kids are going to be that way because they're taught this learned behavior. So that learned behavior just goes, generation to generation, and that is the issue. So if you can break that cycle, oftentimes you'll find, even though they may have a propensity to hypertension or diabetes, you can stop that. But getting in that cycle is not easy.
Not easy. Matisse joins us from Newport News. Hi, Matisse. You're on the air.
Hello. I just want to make a couple of very, very important points about nutrition. My job is to provide education for hypertensive patients. I work at a community health center in Suffolk, Virginia. And what I find to be true is people don't understand nutrition. And the way I know that's true, if you ask them how much sodium should you consume a day, the majority of people don't have a clue. And then you ask them how to read a label, a food label, to determine how much sodium is in the food, people just didn't get that somewhere. So I would say ask your physician to make you an appointment to a nutritionist. You need to see a nutritionist so you can really clearly understand nutrition. And I think that's where a lot of people have problems. And that's the point I wanted to make.
Okay. Thank you so much for that call. That diet and lifestyle change really does make a difference.
Yeah, we try to, what I try to do myself, because you have patients or you have a doc will say to the patient, you need to cut down on the sodium. And when I see somebody with high blood pressure, the first question I ask is, well, what have you heard? And they say, well, I was told to cut back on my salt. I said, well, what does that mean? And they said, well, to cut it back. I said, well, cut it back from where to what? I said, because I could tell you to cut back, and you could be eating 50 grams of sodium a day, and that's, I should say, you'd say, okay, I cut back to 49. I'm like, well, that's still too high. Right. I said, do you have a number specific that you're shooting for? And he is very accurate about the labels because most people don't look at the labels,
and they don't know how much sodium is in the food already.
They don't understand portion size. Like they'll say, if it says it's 5 servings in that, they'll see like 500 milligrams of sodium. Oh, I can eat this whole thing. But it's actually 500 times 5.
Right.
And that's the part that people don't understand, is you have to look deeper than just what the label says, and they'll just look at that and forget everything else.
Is there a number that's too low?
No, because you'll end up eating something regardless. I mean,
no. I'm sorry. I meant a blood pressure number. That's too low. I'm sorry.
Well, that's individualized. Usually, what I try to do, and this is more something we just do kind of routinely, is try to keep pressures above 100, top number. And the bottom number we usually try to keep above 50. If your bottom number gets too low, then you will decrease coronary perfusion, meaning that the actual, because the arteries in the heart are perfused in diastole, meaning systole is when the heart contracts, diastole is when it relaxes, and when it relaxes, that's when blood flow goes into coronary arteries. So if the number drops too low, you can get underperfusion of the heart, which can lead to symptoms of coronary disease, chest discomfort, shortness of breath, what have you. But in terms of top number, we more or less stick to like this 100 number. But I can't say that we really have hard data that says that. But I usually like to go on the patient's symptoms. I look at their lab work and their symptoms. If they tell me I'm getting lightheaded, and some of it is how fast you bring a pressure down too. If I have somebody whose pressures are like 200 over 120, like that young lady who called in earlier, my job would be, as I look at it, the first step is, okay, I would want to probably bring her in the 160 range first. And then you'd leave her there for a bit and then bring her down, because what has been my experience, when you bring them down too fast, then they start fussing at you because they say, I feel lousy. And I'm like, yeah, but this is where your pressure needs to be. I'm trying to keep you alive. But they feel worse because they're so used to having that pressure being skyrocketed for so long. The body's gotten adjusted to it, but it's not a good adjustment.
But okay, so if somebody's blood pressure is at 220, 200, but we keep talking about there are no symptoms. I mean, I can't imagine that there's nothing you feel.
Nothing. A lot of people. That's why they call hypertension a silent killer.
Wow.
Because a lot of people don't feel anything.
I'm looking at Audrey because your numbers were really high at one point. I mean, you didn't feel anything different at all.
Every now and then I had a headache.
But that was it. And you didn't attribute that to anything. You just thought you had a headache.
I attributed that to sinuses.
And understand that everything in medicine is relative too. And when I say that, I mean, if you have somebody who has, it's like if they're, most people with hypertension, it's not like it just like hit them all of a sudden. It's a gradual thing. So you can have somebody whose pressures are sky high for a long period of time. They've gotten so used to having it that high that they don't even realize they don't feel bad anymore. They just look at that as their new normal. So when you ask them how you feel, they say, I feel fine. I feel great. But when you actually get them better, man, I didn't realize how bad I felt until I felt better. And unfortunately, so that's the other reality we have to deal with.
Absolutely. John joins us from Suffolk. Hi, John. You're on the air.
Hi, how are you doing?
Doing good.
All right, so I guess I want to ask a couple questions. It might be a little bit all over the place, but, I recently sat and listened through, I think it's Dr. Wallach's Dead Doctors Don't Lie. I have a family history of high blood pressure. My grandmother passed away in her mid-70s. My mom's been taking high blood pressure medicine since she's been about, I think, like 18 years old. She's in her mid-60s right now. So I've just been we eat very clean. We watch our diet. I exercise. I'm in the Navy, so I exercise upwards almost 4 times a week, pretty decent cardio sessions. I went in today and had my blood pressure taken. It was about 137 over, I think, like 89. And I'm more concerned that down the road that I could potentially, if it's hereditary, that I would have high blood pressure. So in February, I started, I don't know if you're familiar with, it's called intermediate fasting, to try to I guess generally better wellness and a better lifestyle. But I guess my real question is that, there's a lot of information, especially I just heard the last caller talk about sodium and how huge sodium is, where, the doctor off of Dead Doctors Don't Lie is like, most doctors get, 1 semester of nutritional training and then the rest is whatever specialty they're in. So I feel like there's just a whole lot of information that I've been absorbing from a lot of different sources that are telling the public and the people with high blood pressure a lot of different things. But does it really boil down to the fact that that every person, their blood pressure is pretty much theirs and its own. And instead of, swathing the paintbrush and saying everybody should be, 120 over 80, that really, how do we know specifically that the last caller that called in with over 200, the caller before that, that, maybe that it's not that they have high blood pressure, that's specific to them. Their blood pressure is specific to them.
Okay, John, I think I got your point where he's just saying that it's an individual thing. Thanks so much for the call, John.
Well, the problem with that theory is, like these studies, like this study they did, they took 9,000 patients. So they took that's part of why they do studies like that, because of that particular thought process. They say, well, maybe, I used to get in these arguments with patients. They say, my pressure is 150 over 90. And I'm like, that's high. No, that's good for me. I'm like, how do you know that? What makes you think that's good for you? That's why we do studies, so we can come up with whatever that number is, and we have hard data. See, as an ex-Duke guy,
You're a data person.
Yeah, I'm a data person, and I'm like, this is how we come up with studies to look at the answer to this question. Now, I do agree with him that each person has to be individualized, but that's the whole point. You don't put people, as I don't put people in a box. Everybody doesn't fit in that box. I have a patient right now whose pressure is 160 over 90, but if you drop his pressure to 140, his kidneys start acting up. So there is some truth to that, but the issue is that that type of person is rare. The majority of people we deal with, we come up with these numbers because they look at and see, when they do the criteria and they say, okay, let's see who's going to have the strokes. And, when I hear stroke alert in Norfolk General, if I'm called in on a case, I guarantee you those pressures aren't 200 over 100. Characteristically, they're 138, 144, over somewhere between 80 and 95. And the majority of the strokes I see, that's where they are. The intracranial hemorrhages are the ones I see with the 200s over 120s. But the basic stroke, that's the numbers I see. So, the thing is, all we can go on is what we see day to day. And we use that experience to help us and to hopefully guide patients.
So we've got about 4 minutes left. Audrey, I want to ask you then, as a patient and the things you've been through, what would you tell people who have high blood pressure now to do? And you're talking to yourself.
First of all, pay attention to your body. Listen to your doctor. Do what he says.
Yeah.
Exercise, control your diet. And it can be controlled.
Okay. And you're going to listen to Dr. Newby?
I definitely am. I learned my lesson.
And as a healthcare practitioner yourself, you would tell your patients that too?
I used to tell my patients
You used to tell your patients that.
Say, do as I say, not as I do.
And how often would you encourage people to get their blood pressure checked?
At least once or twice a month, if you haven't had any problems. Just for FYI, because you never know. Okay. Because I was 50 when I was discovered, over 50, so you never know.
And Keith, in terms of just overall health, we're trying to prevent, do some prevention as well as control, right?
Always prevention. So, if you get this stuff early, don't let the fact that you don't have symptoms keep you away from your doc. At least once a year you should have your annual physical. And, if that pressure's high, don't just blow that off. Don't say, well, just because I'm coming here today and I get every excuse from, well, because I had a pork chop last night to, well, traffic was bad coming in. I'm like, listen, that may be true, but we don't know that for sure. So what, and I always encourage them to, find some way of checking pressures outside of just the doctor's office so we can see. And if it is high, then we do something about it.
Well, if somebody comes in, you take their pressure in the office. Will you send them back out into the waiting room to make them wait for a little bit and come back and check it again?
Yeah, I usually what I do is by the time they've seen them, we've done our whatever, and if I need to do any testing, I usually tell them, say, okay, before they leave, let's test it again, see where they are. But even if it's still high, I would oftentimes have them check it at home or somewhere else, because I think it's important that we don't drop them too low. Because again, if they do have white coat syndrome, and look at it like this, say they're coming to office and 150 over 90, but at home they're 110 over 70. Then I go give them a bunch of blood pressure medicines. I can make them 60 over 40, and this, they're blacking out. Mm-hmm. So what I try to do is encourage those patients to, let's see if this is a real number. So I get them various places so we can then see and then make our recommendations.
Okay. All right. So Dr. Keith Newby, thank you so much. We'll see you again next month.
I look forward to it.
And Ms. Audrey Thomas-Tarboro, thank you very much. And we hope you take good care of your health. And we will be right back.
Slavery did not begin because of miscommunication. Jim Crow did not happen. Jim Crow did not happen because people somehow couldn't get on the same page. That these were systems that were designed to exploit one group of people to the benefit of another group of people. And unless we're willing to talk about this, these connections between what Dylan Roof saw as himself as a part of an aggrieved group of people who were besieged by black people, which is the same thinking that animated the violent attacks on black people in this state after Reconstruction. The white belief that black people had something that they were not entitled to, that somehow or another that they were losing out, that the currency of whiteness had been devalued. And this is what we're talking about here. And so it is about interests, it is about who has resources, it is about who has excess resources, and it is about who is willing to part with those resources.
That was Jelani Cobb, a history professor at the University of Connecticut. Just one of the powerful comments heard during the PBS town hall meeting after Charleston that aired this past Monday evening on our sister station, WHRV-TV. It was hosted by NewsHour's Gwen Eiffel, and it was an opportunity for the residents of Charleston to talk about how they feel about race relations in the aftermath of the killing of 9 African Americans during Bible study at the historic Emmanuel AME Church this past June. Lisa Godley shares more of the conversation with us.
Our children need to know what happened to black people in this country. They have to know that 4.5 million people were set free in this country with absolutely nothing and were asked to pull themselves by their bootstraps.
As a white man, my main purpose in life right now is to get out of denial, to unlearn the racism I learned growing up here in the South, and to help other white men especially to do that, to become part of the solution.
Why? I mean, what made you start thinking this way?
Grief, I think. Grief at my own upbringing, at knowing that I was taught wrong, and that I want to unlearn that and help teach right.
In this country, housing and land is the greatest source of wealth, transformation, and accumulation, but it's also the greatest source of discrimination. And so it's easy for us to say we don't want those people to live in our neighborhood and to have those people segregated and congregated in another neighborhood, but then we question, well, why are their schools failing? Well, they live in a neighborhood where that's all there is. There's no economic development activity.
To talk about what a solution looks like, it really looks like black people holding powerful positions in cities and towns and school boards and sheriff offices and a lot of the communities that some white people are not prepared for. They're not prepared for a policy that levels out the land, that levels out the jobs, that levels out the quality of education and healthcare services, because they believe that, it should be a place where they live in abundance and some people live in scarcity. And that's what a solution truly looks like. And we've never gotten to a point. We've never truly gotten to a point where we wanted to talk about that.
Even after the town hall, the conversation continued with Twitter polls asking questions like, does American society put too much emphasis on race? 24% said yes, while 76% said no. Are race relations better, about the same, or worse than they were a year ago? 0% said better, 22% said about the same, and 76% said worse. Another question posed was, is the Confederate flag a symbol of Southern pride, racism, or both? 10% said Southern pride, 67% said racism, and 23% said both. Most in attendance agreed that for real change in perceptions and attitudes to occur in this country, the conversation must continue. And you have an opportunity to be a part of the conversation during our latest initiative, Race, Let's Talk About It.
And just as Lisa said, tomorrow the conversation continues here in Hampton Roads as WHRO, Virginia Wesleyan College's Center for the Study of Religious Freedom, and the Fort Monroe Authority present the first of 4 town hall meetings on race relations. The initiative is called Race, Let's Talk About It, and it will be held on the campus of Virginia Wesleyan in the Boyd Dining Hall at 2 p.m. That's tomorrow. Rain or shine, we will be there. It's free and it's open to everyone. Tomorrow's topic is The Flag is Down, Now What? And we're going to talk about how to move from symbolism to true understanding between the races. Now, this is a community conversation, so the conversation is amongst the community, and we really want you to attend. Please go to whro.org/talkaboutrace and register. That's all we need you to do. So that we can make sure we have enough seating. The town hall is a part of the One Love Festival, and just before our town hall, we'd love you to attend the presentation by Professor and Mrs. Robert Watson, who will discuss race in America from Point Comfort to Ferguson, where we've been and where we are. That's at 1:00 p.m. also at the college. So there's a whole lot of things going on at the One Love Festival tomorrow, Saturday, September the 26th. The entire festival runs from noon until 9:30 p.m. at Virginia Wesleyan College. That's at 1584 Wesleyan Drive in Norfolk. The series that we're doing, Race, Let's Talk About It, is a series that Another View has been talking about for quite a while now, and we're very excited about this series, and we're very excited about our partnership with the Center for Religious Studies and also with the Fort Monroe Authority, because we feel that it is an opportunity for all of us to be able to come together and to work through some of our issues. So tomorrow we will kick it off. We hope that you all will come out, that you will join us, that you will be open and ready to have some honest conversation. We have an incredible panel of people who will help us to guide us in the conversation, and we really, really hope to see you there. Again, it is tomorrow at 2 p.m., the Boyd Dining Center on campus at Virginia Wesleyan College. And that's our show for today. If you'd like to hear it again or share it with a friend, go to our website, anotherviewradio.org, and download the podcast. You know, our health is so important, so please share this show with a friend. And you can also sign up for our eView newsletter. It's a once-a-week reminder of upcoming programs. And next week, we're going to talk about the next topic in our Race, Let's Talk About It series. We're going to talk about white privilege, what it is, and how it affects race relations. Our theme music was composed and performed by Jay Sennett. Lisa Godley is our show producer. Victor Bowen is our audio engineer, and Kamaria Mason answered our phones. I'm Barbara Ham Lee. Have a great weekend, everyone. We hope to see you tomorrow. Don't forget, Virginia Wesleyan, 2 p.m. for Race, Let's Talk About It. Have a great weekend. We'll see you again next Friday at noon for Another View.